Well, we are so happy to welcome back Dr. Avrum Bluming to answer some questions. I am Monica Molenaar, the co-founder of Alloy Women's Health, an online service for women in menopause that offers access to menopause literate doctors, primarily OBGYNs later in their careers who are going through menopause as well as direct-to-your-door delivery of certain prescriptions for menopausal treatments from our third-party pharmacy that are all evidence-based, science-backed solutions for menopause. And we are super excited to have Dr. Avrum Bluming back, renowned breast oncologist and co-author with Dr. Carol Tavris of the book Estrogen Matters, and author of many articles, such as the one recently in the Cancer Journal, and others like it, called Estrogen After Breast Cancer, It Is Time. So Dr. Bluming is back to answer some of the questions that women asked in the chat during our recent webinar on managing menopause after breast cancer. And I just want to reiterate how thankful we are to have you back, and how important it is to get this science-backed, medically validated information and solutions to women who are just being forced to become experts in everything related to breast cancer and breast cancer, types of breast cancer treatments, while managing their own emotions and those of everyone around them. So we recognize that it's a very difficult time when you get a breast cancer diagnosis or you've gone through breast cancer, and then having to manage everything that comes afterwards is so hard. So we're so grateful for you to be sharing this information with us, and as many times as we hear it, it's just never enough. So I think we're going to get into it, and thank you so much for talking to us, because usually women aren't given that much support to manage the symptoms that arise from estrogen deprivation as a result of the treatment for breast cancer, or just naturally going into menopause. And given how many safe and effective treatments we have available, it seems like there should be a lot more shared decision-making among physicians and patients. I know you agree with that. So we are looking forward to hearing more of your point of view. I'm going to jump into it. I think the first and most fundamental question, which is also the most vexing question, this is verbatim from the chat and from our webinar: what exactly is the relationship between estrogen and breast cancer? And this woman wrote, there are so many facts that seem baffling together, like an ovarectomy reduces the risk of developing breast cancer for BRCA carriers, but also BRCA carriers who've had ovarectomies can have estrogen replacement without reducing the ovarectomy's benefits. Tamoxifen and aromatase inhibitors are effective breast cancer treatments, but taking estrogen after breast cancer treatment doesn't cause recurrence. People who've taken oral contraceptives have lower risk of breast cancer and ovarian cancer, and women can become pregnant after a breast cancer diagnosis without worsening prognosis or causing a recurrence. How are all of these things true when they seem contradictory?
I think that's an excellent question. And if you're tuning in to hear an ultimate answer, this is the wrong program for you, because I don't have ultimate answers. Yeah. Most of what happens in the world today that we take for granted is based on quantum mechanics. Quantum mechanics allows our clocks and our communications and most of our high-tech equipment to work. And when quantum mechanics physicists asked the founder of quantum mechanics to explain it, his answer was, shut up and calculate, meaning, I don't understand it. And yet the data that we have allows us to make these calculations that allow us to land people on the moon. And unfortunately, that's where we are today with breast cancer and estrogen. It is logical to say that estrogen increases the risk of breast cancer, logical, because women have 100 times the incidence of breast cancer that men do. But it's just not true based on what we know. And it's very important to keep an open mind on the data. And when the data tell us something, we should pay attention to it, but the data have to be accurate data. And that's where we stand. And what we know based on the data is that women who take estrogen are not at an increased risk of breast cancer development if they take it postmenopausally. That in fact, the largest double-blind randomized study in the world, the Women's Health Initiative, about which you and I have spoken in great length and which I don't always respect, found that women who were randomized to take estrogen had a 23% reduced risk of developing breast cancer and a 40% reduced risk of dying of breast cancer. Those data are comforting and allow us to allow women to take estrogen to get the benefits vis-a-vis bone health, brain health, decreased colon cancer, decreased diabetes mellitus, and the best treatment for symptoms. I could go on, but the bottom line is I don't understand the contradictions either. I wish I did.
And when you talk about HRT or hormone replacement therapy after breast cancer, are you referring to all types of breast cancer, including ER positive breast cancer, estrogen receptor positive breast cancer?
Based on the data we have, I am unequivocally. As I mentioned in the article, there were 25, there are now 26 studies of women who were given hormones after treatment for primary breast cancer. Of those 26 studies, and we've reviewed this, only one showed an increased incidence of recurrence, 1 out of 26. 4 showed decreased risks of recurrence. 5 of them were prospective randomized studies. And that one that showed an increased risk of recurrence was challengeable. The recurrence was only a local recurrence, not an increased risk of distant recurrence, not an increased risk of death from breast cancer. And with a local recurrence, you would expect that an admitting requirement for women joining that study, women who had breast cancer, would be at least a baseline mammogram. And in fact, that was not a requirement. So that one study that said there's an increased risk of local recurrence, I don't.
You don't know if women had breast
point.
cancer when they were admitted into the study.
Absolutely. Right. And the fact that they didn't have distant recurrence or death from breast cancer is reassuring.
That's one thing that I've really come to really understand about sort of when you look at these studies, you have to understand what they were trying, what the questions were that they were asking in the first place, who was in the study, how they were developing it. But if you don't ask the right questions, you won't get the answer that you won't necessarily get the answers that we sort of assume we're supposed to have. But a lot of times the studies haven't been set up to answer every single question.
That's a wonderful insight on your part, Monica. And the way science is supposed to work is you develop a hypothesis and you test the hypothesis. You test the hypothesis using what is called a null hypothesis, which means you assume that what you are hypothesizing is wrong, and you do everything you can to prove that it is wrong, not that it is right. And only after you are unable to prove that it is wrong do you say, maybe I've got something. And so many studies that are published today with numbers that sound convincing are not done that way. They're done to try to pluck out data from the study to reinforce what you thought was right in the beginning, even though looking at all the data as you should, don't confirm that.
Right. Yeah, and then once the media start, piling on, it's very difficult to dislodge these incorrect assumptions. So,
right.
Question I have, you mentioned it sort of offhand, but completion of breast cancer treatment and timing. You said when you've completed your primary treatment, then you can treat the menopausal symptoms. Can you take us a little deeper into that? What do you mean by that?
I certainly can. First, be aware that we used to tell premenopausal women who had diagnosed breast cancer that we should take out their ovaries to remove their estrogen. And there were quite a few studies, at least 7 that I was able to find that did that. And the overall result was it probably doesn't matter. We don't take breast cancer lightly. I don't want any woman to develop breast cancer, but I also want women to live as long as they can, as well as they can. And since we don't take it lightly, I think it is reasonable to say that a woman who is considering taking hormones, who has breast cancer, should finish at least removal of the primary tumor, either by mastectomy or by lumpectomy, usually with radiotherapy, so that there's no evidence of cancer in her body. The next question is, what is her prognosis after that initial treatment? And there are nomograms, and we spoke about this in the last session.
Yes.
There are online nomograms that physicians can access so that they can tell you, based on the size of the tumor, the hormone receptor assay, the HER2 amplification assay, the number of lymph nodes, what the likelihood is of recurrence. And you can ask your doctor, if I stop now, what is the chance I will have a recurrence? And if I go on to have additional, what is called adjuvant therapy, adjuvant meaning there's no measurable cancer left, but I want to reduce my risk of recurrence, what is the likelihood of recurrence at that point? Clearly, after the primary treatment, which is getting rid of the primary tumor, I think it is reasonable not to start hormone therapy, not because I know it's bad, I don't, but it's reasonable. Since we don't know the environment, we don't know why the breast cancer started, we try to change the environment that the breast cancer was comfortable enough in to get its start, so that we reduce the risk that it will recur. But after that primary treatment, it is reasonable to sit down with your doctor and say, what is the chance of it recurring with or without adjuvant therapy? And what is the chance of it recurring with or without hormone replacement therapy? And the additional issue is, what kind of adjuvant treatment am I going to get? And I can go on and on if that's all right with you, or
Yes, could you
okay.
go through some
All
of the, some of the adjuvant treatments and how they may differ depending on the type of breast cancer also. So, and also I just want to put a pin in, if you have had breast cancer, let's say a friend of mine 16 years ago had an in situ ductal breast cancer, removed, double mastectomy, ovarectomy. Now, 16 years later, nobody has given her any sort of hormones, vaginal or systemic. Can you start this many years later if you haven't been taking? So let's.
Okay, well, let's answer that question first, because if I keep talking, I'll forget it.
Okay.
The first question is vaginal estrogen. As best I can determine, there is no prohibition that is data supported against vaginal estrogen. Looking at
For
the
anybody.
overwhelming data for anybody.
Yeah.
And vaginal estrogen is very good for treating genital urinary syndrome, which is dry mucous membranes in the vagina causing frequent urinary infections and
terrible,
difficult sexual intercourse.
Yeah.
And it's the best treatment for that.
It's the best treatment, totally works.
Right, there you go.
Stops you from peeing in your pants.
Okay, which is good.
Yeah,
Okay.
it's good.
The next question is, we're talking primarily about women who are estrogen receptor positive, with or without being progesterone receptor positive. And they are often, not always, but often given adjuvant therapy that is meant to reduce the risk of an estrogen receptor positive recurrent breast cancer. And there are several treatments now. The initial one was tamoxifen. And tamoxifen was initially sold as an estrogen receptor blocker, meaning that estrogen is believed to attach to the receptor on the breast cancer cell and stimulate the growth of breast cancer. And an estrogen receptor blocker was meant to prevent estrogen from gaining access to that receptor. We were told at that time that tamoxifen should be given only to postmenopausal women because tamoxifen did not have the same affinity for the estrogen receptor as did estrogen. If I use words that are confusing, you stop me right away. Okay.
I will.
Good.
I'm holding on.
Okay, that's fine.
Yeah.
And so we gave it to women who were postmenopausal, who had low levels of circulating estrogen, and we found that tamoxifen did, in fact, help prevent recurrence of the cancer in these women. We subsequently found that it works even better in premenopausal women than it does in postmenopausal women. And in premenopausal women, giving tamoxifen raises the level of circulating estrogen by a significant amount, 3, 4, sometimes 5-fold. And so any effect of tamoxifen in blocking the estrogen receptor so that estrogen doesn't have access to that receptor would be overwhelmed by the circulating level of estrogen. And in spite of that, tamoxifen worked just as well, even better in these women than in postmenopausal women. So we had to rethink how tamoxifen works. And there are now 10 different ways that it works, independent of blocking estrogen receptor activity, estrogen receptor for estrogen. And I'm not sure which one is the dominant one. But, and this is the getting back to your question, Craig Jordan, who's called the father of tamoxifen, probably the man singly most largely responsible for bringing tamoxifen to market, has said, you know, in giving tamoxifen to a premenopausal woman with the dramatic rise in circulating estrogen does not interfere with the effect of tamoxifen, why would it be harmful for postmenopausal women to take a relatively small amount of estrogen to help their symptomatic problems? There hasn't been a large study looking at that, but I respect Craig Jordan's
help their
overall.
symptomatic problems and prevent the chronic diseases of aging.
The reason I didn't put that tagline in is since there hasn't been a large study, you can't sell it that way. But certainly it helps treat symptoms. And so giving tamoxifen with estrogen is not an unreasonable approach if you recognize the limit of the data we are accessing. Now,
and how do women get that treatment? How do they convince their doctors, or beyond reading Estrogen Matters? I mean, it's you know, I think that's really where the break comes, right? Which is
Saul Bellow, who won a Nobel Prize for Literature, was asked, how do you write a book that gets a Nobel Prize? He said, first, you get a plot. Well, sure. And first, you have to find a doctor. And what you and I, and fortunately many other people in the world are trying to do now, is make sure that doctors are informed enough to have intelligent shared discussions with their patients about this. The one other issue is aromatase inhibitors are a later form of therapy for women who are estrogen receptor positive, for postmenopausal women. And aromatase inhibitors work primarily by preventing the synthesis of estrogen from testosterone. Testosterone is the largest precursor of estrogen in women through the enzyme aromatase, and an aromatase inhibitor prevents this from happening even in postmenopausal women. And it also works in postmenopausal women in helping recurrence of cancer. And so many physicians will tell you, well, I don't want to give you the old treatment, tamoxifen. I want to give you the most effective treatment, aromatase inhibitors, in preventing recurrence of breast cancer. And it makes no sense to give you something that works primarily by preventing estrogen synthesis at the same time I'm giving you replacement estrogen. I think that's correct. It makes no sense to me either. But the difference in effectiveness in preventing recurrence between aromatase inhibitors and tamoxifen in postmenopausal women is less than 5%.
Wow.
And so that has to be put into the mix when you are reaching a decision of, well, would I like to take aromatase inhibitors alone that might increase my chance of never having breast cancer again by a couple of percentage points? Or am I having such difficulty with the symptoms that I prefer to take tamoxifen? And if that is working well, add hormones afterwards, recognizing that I don't have hard data studies supporting the safety of that approach. I wish I could give shorter answers, but it's
I
hard.
know, but there's so many years of studies. And didn't breast cancer actually used to be treated with estrogen?
Oh, yes. The
So,
first treatment we had, before we had chemotherapy, before we had drugs like tamoxifen, was high-dose estrogen.
yeah.
And in fact, there was a 44% response rate of measurable breast cancer in women given high-dose estrogen. And so when I would debate with other people who didn't agree with my point, they'd say, sure, high-dose estrogen is okay, but low-dose estrogen is bad. Well, wait a minute. First, what are the data for that? Well, there weren't data at the time. It just sounded right to these people who had this problem with giving estrogen. And in fact, what Craig Jordan showed is women who become resistant to tamoxifen with progressive cancer can be treated with low-dose estrogen and get a secondary response of the cancer.
Meaning positive.
Meaning the cancer would regress on
go away.
exposure to low-dose estrogen.
Yeah. That's amazing. So is there a path to advocate for women not to, I mean, how long do you take the tamoxifen? I mean, at a certain point you can stop the tamoxifen and just take the estrogen, or do you
Well,
take
what's
tamoxifen?
interesting is the first accepted dosage and duration of tamoxifen was 20 milligrams every day for 5 years. And that did seem to help prevent recurrence. And because a little is good, it was thought a lot was better. So they did a study and said, 10 years is better than 5 years. Well, wait a minute. First of all, the 10 years really was primarily for women who had significant lymph node involvement, not women who had no lymph node involvement and a projected cure rate of 90+% in the absence of any adjuvant therapy. But 10 years held for a while. Now, again, we're looking only at studies, but it's important to understand the data in the studies. We've gone back to 5 years, especially in women with a favorable prognosis, to now it's been shown for at least 7 years, 5 milligrams, not 20 milligrams, daily for 3 years appears to be as good as 20 milligrams daily for 5 years. Now, that's only 7 years worth of follow-up, but stay in tune and in touch with the data and fashion your treatment based on accumulating data. And again, now
Start with 3. And
well,
if after 3,
well, you can, I can't say start with 3.
no, I understand, but if I'm understanding, the guidelines now are changing, that it looks like the data is showing that 3 years is as good, 3 years is as good as 5 years.
5 milligrams a day for 3 years, maybe as good as 20 milligrams a day for 5 years.
So that's a significantly lower amount of tamoxifen.
And women with very favorable prognoses are now being spared any adjuvant therapy whatsoever. If you have a 90+% chance of cure, to improve above 90+%, because nothing in medicine is guaranteed 100%, nothing. to improve above 90+% is going to require a study of hundreds of thousands of patients for 20 years. We're never going to do that kind of study. And so you can have a legitimate discussion saying, I'll take 90+%, and unless you can show me that I'm doing something bad to myself, I might even consider HRT.
Right. And I guess one thing is helpful to step back, a little bit further and to say, why do we care so much about HRT in the first place? What is some of the data showing, what does it do? How does it help? And why is it so important why are we talking about estrogen and making a big deal of it?
First, I assume most of the people listening to this listened to our last discussion in which we discussed this, but this I can answer very quickly. All right, in 1999, it was shown that if 99% of women in the United States took hormones at around the time of menopause, they would prolong the median survival of women by 3.5 years. 99% of women. We now know that heart disease kills 7 times as many women as breast cancer does in the United States each year. And what people usually say is, well, heart disease kills old women and breast cancer kills young women. And if I'm going to die, as we all will, I'd rather die old than die young. Well, in fact, from age 40 on, the likelihood of dying of heart disease is greater than the likelihood of dying of breast cancer. And that difference dramatically increases in favor of heart disease against breast cancer as we age. And estrogen reduces the risk of heart disease by 50%. That's significant. Almost as many women die in this country each year associated with an osteoporotic hip fracture, which affects women in menopause. And estrogen reduces the risk of osteoporotic hip fracture by close to 50%.
So then this gets back to my question of, for women who have had breast cancer on the younger side, for example, and they go through their primary treatment and they have years afterwards with no recurrence, and they've done whatever, surgeries, mastectomy, ovarectomy, etc. What we also know is that the sooner you take estrogen when you enter menopause, so the fewer years you have with your cells becoming estrogen deprived, the better the protective benefits in the long run. So what do you say to women who have been now who are hearing your message, who are hearing like, oh, maybe there's an opportunity for me to feel better and to treat some of these symptoms that I'm suffering from, but it's been 10, 15 years. How do you counsel women at that point?
Here's the concern about that. The benefits are still the benefits. And that's vis-a-vis heart disease and preventing cognitive decline and keeping bones strong and decreasing the risk of colon cancer and diabetes and improving quality of life. The problem is, as we get older, and this is true for all of us, regardless of what medicines we're taking, our blood vessels become less elastic and they narrow. Happens to all of us. Platelets are small corks that circulate in our blood, which is a good thing because they help prevent bleeding. When you cut yourself, platelets rush to the side of the cut. They form a plug that prevents the bleeding. It's a good thing. People with deficient platelets bleed way too much. But estrogen has the potential of causing platelets to clump. And clumped platelets can block an already narrowed small artery to a vital organ and cause a problem. And in fact, if that small artery is going to the heart or the brain or to another vital organ, that problem could be a major problem. That was encountered in the Women's Health Initiative among women who were more than 10 years post-menopause. Is that true for every woman post to more than 10 years post-menopause? No, it's not. How do you differentiate them? Well, if you had access to every possible test, what you could do, and I'm not suggesting this, is you could do arteriograms looking at the small vessels in the heart and the small vessels that go to the brain, and see if they are already narrowed. Well, there are risks to that kind of test too, so you don't want to do that. When I was faced with that clinically as a 4-second choice, I would do ultrasounds, which are non-invasive studies that could look at the expansibility of arteries, of the large arteries, the carotid to the brain, the coronary artery to the heart, and see if they look stiff.
Yeah.
And
I
if
mean,
they did, that would be a concern.
I think it's
Interestingly,
interesting
one
what I,
other question, one other answer, and I'll finish. That increased risk of problems was seen primarily during the first year of treatment in the Women's Health Initiative, and then it evaporated. But if you have a catastrophic event during the first year, you're not a happy person.
right. I mean, I think what's interesting though, is this is also where lifestyle comes into play a little bit more. As I understood it, the women who were in the Women's Health Initiative were actually enrolled because they already were at risk for heart disease because of their advanced age, because they were generally obese, they were smokers, they had already the risk factors. And the question was, and this gets back to, if you ask the wrong question, you're going to get the wrong answer. The question was, would giving estrogen to these women fix the already sort of diseased arteries, et cetera, the cardiovascular disease that they were at risk for? And what we learned is that no, it doesn't. If you already are at, from whatever reasons, whether it's poor diet, smoking, whatever, you have, and age, you have more sort of damaged arteries than somebody else who has lived a healthier lifestyle, more exercise, more movement, more stress reduction, et cetera. No two people are the same. But obviously the more, and this is like Dr. Peter Attia is talking about this all the time, the last decade, that marginal decade, you can't get there healthfully if you don't live the prior 3 decades, as well as possible, eating well, moving well, et cetera. So
I think the biggest contribution, and this is from senior investigators in the Women's Health Initiative, is the lesson we got from the Women's Health Initiative is there does seem to be a safe period, which is within 10 years from the last menstrual period. And after that, it's not forbidden. It is still a balance of benefit and risk. But after that, the risk may be as great and the benefit might not be as good.
right. Or everybody has a different risk benefit profile, if depending on what your symptoms are and how badly you're suffering, if it's your risk is an additional, I don't know, 5%, 2%, 3% of recurrence, you might be willing to go for it because, of all the other reasons why you would want to have it. So that's where shared decision-making is so important, that at least women patients will have a voice to talk about their whole self as opposed to just one thing, which is breast cancer prevention. I think
I joined the many oncologists who are advocating for shared decision-making.
Yeah, it's very important. All right, I want to dive back a little bit more into some weeds questions. Can you please explain the difference between ductal and lobular tumors and cancers, and the main differences in risks and recurrence? Many women asked about lobular and mentioned having heard that it's more challenging to treat. Is this the case? What are the common treatment differences between the two? And is there a difference later on in how you would treat menopause subsequent to these two different types of breast cancer?
Okay, the answer to the last question is no. I wouldn't treat them differently. And we don't. the answer to the first question is, if you think of the architecture of the breast, then it would be nice if we had a diagram.
Next time.
The breast has ducts that make up the glandular tissue in the breast, and the ducts end in small sacs in which the milk is made. And the ducts convey the milk from inside the breast out to the nipple so the baby can get the milk. And ductal carcinoma, which is about 85% of breast cancers, is the most common. But if you have cancers in the small glands, lobules where the milk is made, it's called lobular carcinoma. Lobular carcinoma is not as easy to pick up on routine studies like mammogram as ductal carcinoma. And lobular carcinoma has a tendency to be present in more than one place in the breast. So that if a woman has a lobular carcinoma, you often want to look very carefully through the breast involved and the other breast to see if in fact that is lobular carcinoma is present there. Infiltrating, well, ductal carcinoma can be in situ, and ductal carcinoma in situ, called DCIS, is limited to inside the duct. It hasn't yet penetrated through the wall of the duct, and that carries an excellent cure rate when it's just removed without additional treatment. Lobular carcinoma, because it's harder to pick up, is more of a problem. First, because it can be multifocal, present in more than one place. And second, it's often picked up later. But lobular carcinoma in situ is actually not called cancer. It's called a predisposition to the development of cancer. And so treating lobular carcinoma in situ is a problem. Do we just watch it, or do we treat it by removing the primary? Well, because it can be multifocal, because the primary can be just one example of it, which could be present in the other breast, the options of treating lobular carcinoma in situ usually are watchful waiting or double mastectomy for this problem, which isn't even called cancer. And not surprisingly, most people opt for watchful waiting, since in the majority of cases, it never develops into an invasive cancer.
Oh, that's interesting. And how long do you typically watch and wait?
For the rest of the woman's life.
Forever. So typically, so if it doesn't grow and doesn't break out, then that's it. And can you then take HRT and live your life?
I told you
Yeah.
at the beginning
Right. Of course you
that
can.
I wouldn't differentiate between those two types, and the administration of estrogen or hormone replacement therapy. And remember, we said that so far, estrogen appears to have either no effect on the risk for breast cancer development or a decreased risk of breast cancer development, and certainly a decreased risk of mortality. And there's one other thing that's worth noting that several investigators in the Women's Health Initiative noted. I told you that tamoxifen has been shown to reduce the risk of recurrence. And we have many, many studies showing that, as do aromatase inhibitors. But remarkably, neither of those categories reduce the risk of death from breast cancer. But you remember early on, we said, women who take estrogen have a decreased risk of breast cancer death. So that unlike these widely used agents, only estrogen appears to decrease the risk of dying from breast cancer. And if your head is swimming now, you're in very good company.
It's frustrating.
Well, it's also very
Exciting.
interesting.
Yeah.
Yes.
No, but I guess it's super fascinating and it's great because, of course, you know, the more we can get the information out, the more women can take advantage of this new and
Everybody else.
powerful
Yes.
information. Very helpful, but still, even as people who are talking about all the time, I just said, can she take HRT, as if we haven't been talking about this whole time that of course women can. So, you know, it's like you can't get yourself out of the headspace sometimes. Anyway, I think it's important to talk about during endocrine treatment. What are the various ways to deal with menopausal symptoms? So there will be women who, you know, don't want to, won't be given a prescription for estrogen. There are other things, or they should be prescribed, or, you know, advocate for estrogen. Let's just talk about through some examples, like specifically like the premenopausal woman on ovarian suppression, or postmenopausal and currently on an aromatase inhibitor. Like, what would you recommend for that category?
You have just walked out of my area of expertise.
Okay.
That's really largely an OBGYN question.
Okay.
And I will defer to my OBGYN colleagues.
Okay, interesting. So, so things like intrarosa or vaginal estrogen, those types of things is not the difference between these types of treatments is not really your area of expertise. It's more the overall data on estrogen and its relationship to cancer, breast cancer.
That's exactly right.
Okay, that is good to know. Can we go into vaginal estrogen though?
Sure.
As a topic? So a bunch of women asked, do you need to have vaginal symptoms in order to start vaginal estrogen, or how do you feel about it as a preventive measure?
Again, we're talking about genitourinary symptoms.
Right.
It's not meant for hot flushes or insomnia or brain fog or palpitations. Genitourinary symptoms, vaginal estrogen is far and away the best treatment. And based on the data available to me, which I check as often as something comes out that's new, is both safe and the most effective.
I'm going to jump around a little bit because I feel like we
Sure.
can get more into, let's stick to different types of breast cancer, because I also think it's interesting. Triple negative breast cancer. We talked about DCIS and what that was about. Triple negative breast cancer. Let's talk about what that is, and then I have a couple of specific questions of people who had triple negative.
Okay, let me just get back to the first question you asked, which was, is there a difference in taking hormone replacement therapy for women with a history of breast cancer if they had an estrogen receptor positive breast cancer? And I don't know if I said it as unequivocally as I should have, which is, of the 26 studies that looked at this and published reports, somewhere between 14 and 18 included estrogen receptor assay values. And in none of the studies, including the study that showed an increased risk of local recurrence, was there any difference between the women who were ER positive and the ones who were ER negative. Having said that, okay, so triple negative. Triple negative breast cancer is breast cancer that has neither an estrogen receptor positive assay, a progesterone receptor positive assay, or a HER2/neu amplification assay. HER2/neu is a normal gene that is present in every cell in all our bodies. But about 30% of women with breast cancer have extra copies of the HER2/neu gene within their cancer cells. And this extra copy cell has a proclivity to be more aggressive. And so HER2 positivity was associated with an unfavorable prognosis until we developed a drug that was called Herceptin, and now there are other drugs like it that neutralize the effect of those extra copies, eliminating the worst prognosis associated with HER2 positivity. A tumor that is estrogen receptor negative, progesterone receptor negative, and HER2 neu negative, meaning it doesn't have extra copies or extra activity of that, also doesn't have targets that we can use to treat, at least as far as we know. And so it was harder to treat, it still is, and it has a worse prognosis, not an overall terrible prognosis, but a worse prognosis than the other forms of cancer. On the good side, because it has a worse prognosis, most recurrences for triple negative breast cancer will recur within a few years. And so if a woman is several years post-treatment and still well, she has a good chance of never having a recurrence, as opposed to estrogen receptor positive tumors that have the potential to recur long in the future.
That's interesting. Here's a question from a woman who said she's triple negative. She had triple negative breast cancer. She completed her primary therapy with surgery and chemo while she was premenopausal, and the doctors allowed her to continue with her ovarian function. Now she's going through menopause and nobody will give her HRT. Doesn't make sense. Doesn't make sense. We agree.
She answered the question.
Be able to get it.
It's also worth mentioning, and I think we've brought it up in previous conversations, that women were told they must never get pregnant after having ER-positive breast cancer because pregnancy will flood the body with both estrogen and progesterone. And a lot of women told the doctors, thank you for your advice, and they got pregnant. And studies now show that pregnancy, as best as we can tell, has no negative effect on breast cancer recurrence among those women, including, and especially most of them, were estrogen receptor positive breast cancer patients.
Here's a question from another woman who was diagnosed at 29 with triple negative invasive ductal breast cancer. Her ovaries were removed at 35, so 6 years later, per her oncologist recommendation because she was BRCA positive. Now she's 38. Sounds like no recurrence. Would estrogen be an option for her?
All right, again, I have to be really careful that while I'm glad to offer as much information as I can, it would be irresponsible to offer specific advice to somebody I've never evaluated in person. And it sounds like she is probably 10 years post her last menstrual period. We mentioned concerns about that, but it's certainly a topic for discussion with her physician. The hope is that
like she's 3 years post her ovaries removed at 35, so she's 3.
So she is still actively menstruating at the time her ovaries were removed.
Yeah, because she was young.
Okay, I didn't remember you saying that, but okay.
Diagnosed at 29 with triple negative invasive ductal breast cancer, ovaries removed at 35.
Okay, but she was treated with chemotherapy, which can sometimes precipitate early menopause, so I don't really know when her last period was. That's why it's so hard to give specific advice. But it's certainly worth a discussion, especially because the hope is she will live an additional 50 plus years, and she might live better and longer on hormones. So she should sit down with her doctor, who should have an open discussion with her.
Right. How long does one typically go on an AI and ovarian suppression? And Is that what we talked about? No, that's not what we talked about. The tamoxifen, the 3 years versus the 5 years versus 10 years. That was tamoxifen, 20 milligrams. Okay, so AI and ovarian suppression, how long do you typically do that for? And what's the general benefit? What do the studies say about the general benefit?
When AI first came out, it was tested against tamoxifen for 5 years. And then it looked like for women with prognoses that was of concern, especially with lymph node positivity, 5 years of tamoxifen followed by 5 years of AI was recommended. And now those 10 years are split up in different ways by different regimens. And there are lots of options for doctors to choose from, which is why I brought up that the difference, that the benefit that AI confers over tamoxifen is not that large, that it's at least worthy of discussion. The doctor may convince you to not take estrogen, but it should be discussed by a doctor who has all the information available to give you the best possible advice, which you could then take or not take.
I think that is the perfect place to end. Women should have the right to engage in their in the discussions around their health and how they want to live their lives, especially for women who are going through this at midlife when you have so many more years to live. And we're so grateful to have people like you who really study the science, who know the data and can help us understand this very complicated.
If I were a woman
Yeah.
and I asked the questions we've discussed of a doctor, and the doctor said, I'm not going to discuss that with you, and if you insist on discussing it, find another doctor. My answer, I hope, would be, how dare you?
Yeah. Well, we actually, a woman came to Alloy, I believe Alloy recently, or one of the doctors, I heard from one of our doctors actually, and I believe, you know, she came to Alloy looking for help, and we do our best. We obviously, you know, have to, this is a very confusing and you know, regulated industry and regulated sort of topic, and lots of just all the misinformation has made it a minefield for everybody. So we do have a lot of things that women who have had breast cancer, we can offer. Vaginal estrogen for sure. We have a non-hormonal solution, paroxetine. We have, you know, topical sildenafil and for sexual health and wellness, which is also great for women who've had breast cancer if you want more feeling. And, you know, so there definitely are solutions, but we can't help everybody because, you know, it's complicated. You need, most likely, if you've had breast cancer, you should have, you know, you'll have an oncologist. You might want to have an in-person visit with, you know, for various reasons, but people still come in and ask questions. And there was a woman who refused an AI, and her oncologist just released her, said, well, then if you don't follow what I'm telling you to do, then don't come back, which is a really, you know, troubling position to be in medicine, that's the response that a lot of women get when they're trying to advocate for their own health, so, and well-being.
We are no longer father or mother figures. We
Yes.
are advisors. And everything a doctor says does not have to be followed. Doctors are generally right, and they're generally very well educated. But in a changing field, the doctor has an obligation to stay abreast of what's going on and to share his or her insights with the patient, who should be able to share hers.
Indeed. Thank you, Dr. Bluming. I'm going to end it there because that was so fantastic.